Thank you, sir. Thank you so much. So without wasting further time, because we are just uh, running late, so I'll be speaking on Tecentriq, that is atezolizumab, that is anti-PD-L1 monoclonal antibodies. So I'll be covering my topic under the following subgroups. So starting that small lung cancer is quite different from non-small cell lung cancer. That is, it is having a rapid doubling time, high growth fraction, high mitotic rate, and although with such poor prognostic factors, it has very high sensitivity to the chemotherapy as well as radiotherapy. Also, it has early propensity for distant metastasis, and all the patients are actually smokers, and 99% of the small cell lung cancers are smokers. Hardly you will find or you will diagnose small cell lung cancer in non-smoker. The median age is 65 years. In contrast to non-small cell lung cancer, where we have lot many actionable targetable driver mutations, here we actually lack these, and we don't have much of target therapy except for the recent introduction of immunotherapy in the treatment paradigm. So small cell lung cancer accounts for around 15% of all lung cancer, and with a very poor or dismal long-term survival rate of less than 2%. So although TNM staging is recommended for small cell lung cancer also, but veteran administration lung group classification is more commonly used owing to its ease as well as less complications. So patients are divided either into limited stage when the disease is limited to one hemithorax or ipsilateral lymph nodes, or extensive stage if the disease is extending beyond one hemithorax or malignant pleural effusion, where it cannot be encompassed safely into one radiation field. So 1/3 of the patients are having limited small cell lung cancer, whereas 2/3 are having extensive. The scenario in our country is more worse, that 3/4 of the patients are having extensive stage small cell lung cancer, and the treatment is depending upon the disease. Limited stage is being treated with the combined modality, whereas extensive stage is treated with the systemic chemotherapy followed by a prophylactic cranial irradiation. So nothing much has happened in treatment paradigm in last few decades in the field of small cell lung cancer, and chemotherapy remains the standard of treatment, along with the radiation therapy as a combined modality in limited stage, or as a prophylactic or cranial irradiation in extensive stage, as well as the thoracic radiotherapy in patients who are having residual disease post systemic therapy. So treatment scenario in India, as I have said, that systemic therapy remains the major modality, and we have actually lack of much targeted therapy except for the recent introduction of immunotherapy. Platinum plus etoposide remains the standard first-line treatment, and around 3/4 of the patients actually receive platinum plus etoposide, and there are patients around 25% who receive irinotecan-based treatment. Although there's almost all the trials have shown that addition of irinotecan platinum does not significantly improve the outcomes except for one JCOG trial. So, but that was attributed to the different pharmacogenomics. So there is an unmet need for the more efficacious treatment in small cell lung cancer, owing to the very dismal 5-year overall survival rates worldwide. As you can see on the left side, and in Indian setting, it's around 2.4%. So what happens with the systemic chemotherapy? As I've said, that these cancers are very much sensitive to chemotherapy as well as radiotherapy, with the overall response rate going to up to 84% and median progression-free survival of 6 months. But of late, majority of the patients actually relapse, with the very dismal 5-year overall survival rate of less than 2 to 3%. So the treatment challenge is that in last 2 decades, nothing much has happened except for very recent introduction of immunotherapy. 2 immunotherapeutic drugs are being approved. One is atezolizumab and Second is durvalumab. Both are anti-PD-L1 monoclonal antibodies, though pembrolizumab has also shown improvement in progression-free survival, but the overall survival outcomes are not statistically significant. So what is the rationale behind the combination of chemotherapy and immunotherapy in patients with small cell lung cancer? First, that these patients are very much responsive to chemotherapy, and the killing of tumor cells will release cancer antigens, which will be presented to the T cells, and blockage of PD-L1 will result in further blockage of PD and PD-L1 interaction that will inhibit the PD and PD-L1 interaction mediated down regulation of T cells, which will further result in activation of T cells, trafficking of more and more T cells to tumors, infiltration of more and more T cells into tumors, and thus improved efficacy of the systemic therapy. So that is the rationale I have already told. So this is the IMpower133, which actually randomized patients with extensive stage small cell lung cancer, where veteran group of staging was used to either atezolizumab or placebo. And if the patient has not progressed after 4 cycles, atezo maintenance versus placebo maintenance was being used. The primary endpoint were PFS and OS, where there were multiple secondary endpoints. Prophylactic cranial irradiation was permitted in these patients, whereas consolidative thoracic radiotherapy was not permitted. But there are at least studies which have shown that even consolidative thoracic radiotherapy are associated with improved overall outcomes. So why only 4 cycles were being given? Because there are multiple trials, both in small cell as well as non-small cell, where it has been shown that more than 4 to 6 cycles have actually improved PFS, but has not improved overall survival. And that too, it has increased the toxicity. And secondly, atezo was combined with carboplatin and not with cisplatin in IMpower133, whereas durvalumab was studied with both carboplatin and cisplatin. But there is a meta-analysis of at least 4 randomized controlled trials, which have seen that similar efficacy of carboplatin and cisplatin, although in non-small cell lung cancer, cisplatin has shown improved overall response rate as well as survival outcomes and as compared to carboplatin. But once carboplatin dose has been modified or increased to AUC or area under curve 6, then these differences were not that much significant. So these were the primary and secondary endpoints. The baseline characters were almost matching in both the arms. And you can see the overall survival, which was the primary endpoints, was significantly improved with atezolizumab. Median overall survival was 12.3 versus 10.3 in placebo. And you can see that 12-month OS was 51.7% versus 38.2%, with a hazard ratio of 0.70. That is 30% reduced risk of progression or death over the median follow-up around 13.9 months. This is the updated OS after the follow-up of 22.9 months, where the 18-month OS in atezo arm was 34% versus 21% in the placebo group. So at 18 months also, patients tend to achieve the benefit from this combination, followed by atezo maintenance. And what about the progression-free survival? Surely progression-free survival was improved, and that was found to be statistically significant with a hazard ratio of 0.77. And 6-month PFS was 30.9 versus 22.4, and 12-month PFS was 12.6 versus 5.4, means doubling at 12 months. And coming to the duration of response, median duration of response was increased with a hazard ratio of 0.7, and also 6 months and the 12 months event-free survivals were increased with atezo as compared to the placebo. And there were more patients with ongoing response in the atezo chemo arm than in the placebo arm. Now coming to the forest plot, you can see that almost all the patients are getting benefit with this particular chemo-immunotherapy combination. And coming to safety profile, you can see that treatment-related grade 3-4 adverse event was similar in both the arms, 67.7% in atezo carbo eto arm, whereas 63.3% in placebo plus chemo arm. And treatment-related serious adverse events were also, you can see that they were almost same, 38.9% in chemo-immuno arm, and placebo chemo arm, it was 35.2%. And there were 11% which resulted in the withdrawal from the atezo arm, and there were only 3% in the placebo arm. So there were actually numerically more patients who were withdrawn or who actually withdrew from the treatment protocol because of certain adverse event, but that too were around 10 to 11%. So this is the summary of IMpower133. So patients were randomized to atezo plus chemo vis-a-vis placebo plus chemo for 4 cycles, followed by maintenance of atezo if patient had any sort of response, and prophylactic cranial irradiation was permitted. So what we can see in the primary endpoints, the progression-free survival was significantly increased with hazard ratio of 0.77, as well as median overall survival at 12 months and 18 months were increased with a hazard ratio of 0.70. And you can see 12-month overall survival of 51.7% versus 38.2%. So there's a difference of around 13.5% between the two arms, favoring the chemoimmuno arm. So these are the treatment guidelines for the patient with extensive stage small cell lung cancer, both NCCN as well as European. So if the patients are having extensive stage small cell lung cancer with no brain metastasis, then systemic therapy, including supportive care plus or minus radiotherapy. If patient is having a poor PS, that is because of the disease itself. But if the poor PS is not because of the disease, then the individualized or the best supportive care. And if the patient is having extensive disease with brain metastasis, asymptomatic, then we have to go ahead with systemic therapy. If symptomatic, then we have to address brain first, then the systemic therapy. So the summary is that IMpower was the first positive trial of chemoimmunotherapy combination in first-line extensive stage small cell lung cancer. And it has shown that the chemoimmuno, because of the various principles of the rationale behind combining the chemo plus immuno, has resulted in significant improvement in progression-free survival and overall survival in this sort of rapidly progressive and high growth fraction and propensity to have early resistance to systemic chemotherapy, where the chemotherapy was only the standard of care in last 20 to 30 years. This combination has actually improved the outcomes, and atezo plus carbo-ito combination is recommended by all the guidelines and other key treatment guidelines, including NCCN and ESMO, for the first-line treatment, owing to its effective survival outcomes in patients with extensive stage small cell lung cancer. So superior survival benefits were demonstrated. As I have said, that median overall survival at 12 months and 18 months was significantly superior for the chemoimmuno, that is atezo immuno arm, atezo chemo arm, rather than for chemo placebo arm. And patients alive at 1 year were 52% for atezo chemo arm, whereas only 38% for carbo chemo arm. And IMpower133 is investigating the combination of atezo with chemotherapy in all comer population, regardless of biomarker status. So the takeaway message is that this disease, extensive stage small cell lung cancer, is highly fatal, rapidly progressive, and with a very high mitotic rate. And we have very lack of any targetable drugs for this particular disease. And the systemic chemotherapy remains the standard of treatment for the last few decades. So, but the introduction of immunotherapy has brought has given some hopes in the terms of improvement, that is statistically significant survival outcomes improvement in patients with extensive stage small cell lung cancer. Thank you.
Yeah, thank you, Dubey. You have very nicely discussed the use of atezolizumab along with chemotherapy in the management of small cell lung cancer, extensive disease. Probably in limited disease with CCRT, probably atezolizumab may be added subsequently for the management of limited disease also. I'm sure the trials may be going on in the limited disease also.
Ah, sir. Presently, the approval is for extensive stage.
Thank you very much, Dubey. And I know this is approved for extensive disease, but trials may be on,
yes, sir,
for limited disease along with the chemo and CCRT.
Sir.
Thank you, Dubey. Thanks a lot.
Thank you,
and very nicely covered the talk. And now we will move